going to queue, picking souls to be in your place. No, man. Telling brother to keep your space for you. No. Do it yourself. Simply swap it everywhere you go. MTN, everywhere you go. Onga says we should win big. Yes, so this time around, Onga is having Ongalicious Binwaha promo for myself and you, so that we'll win big. If you are ready to win big, please join me this morning so we do the winning together. So over 4 million worth of Ghana cedis, cash and prizes to be won. Just look out for the special Ongalicious promo packs. Submit 20 Onga powder promo sachet and 20 Onga shrimp tablet promo wrappers at any Onga redemption center near you. And what you do is that you receive a scratch card, and you scratch the card to reveal your unique code, and send that unique code to *713 *27 hash. Let me do that again. *713 *27 hash, and win instantly. There and then, no, you win. Cash prizes are up for gains for up to about 200,000 Ghana cedis. Deep freezers, smart TVs, kitchen appliances, and more. Promo runs from 15th April to 15th July 2026. Hurry, don't miss it. Hurry now. And remember, terms and conditions apply. For us here in the Upper East region, you can call Frima Zuma. She's the agent. You can call her on 0201 862231. 0201 862231. And that is at Mr. Alex shop around Sawaba. Azuma Joyce is also on telephone line number 05080655506. 05080655506 at Get Rich Supermarket. Right opposite St. Francis Pharmaceutical. That's St. Francis Pharmacy. And adjacent Snap here about building. That is, I think that should be a larger than Ladi Palace 5. And you can also call Elizabeth Kurbiri also on 0241 530049 at Queen Latifah Supermarket. You can also call Linda too as well in Navrongo. So for those of us who are inside Navrongo and listening this morning, want to be part of the promotion, call 0242 299 022 0242 299 022. That you will be assisted on how you will be part of this promotion exercise and win big for yourself, win big for the family, and use that to start your business if you so wish to do so. All right, so we're hitting the phone lines this morning to have a conversation with Patrick Namo. He's the secretary to NGOs in health here in the Upper East region. About 4 days ago, the President of the Republic of Ghana launched a policy that will help myself and you get free primary health care. And so we want to speak to him this morning in that regard. So whilst we are making effort to get him, we may just remind ourselves a bit of what the President said that day during the launch. All right, so I understand we have our good friend Patrick Namo on the telephone lines to speak to us. He is the Regional Secretary for NGOs in health here in the Upper East region. Hello, good morning. Hello? Wow. We seem not to be getting our good friend Patrick. So let's take a listen to the President briefly on that. The President of the Republic of Ghana.
I want to emphasize the importance of the free primary health care. We've been talking about universal health coverage. every country is working to achieve universal health coverage. And universal health coverage is the situation where every citizen has access to quality, affordable care. In Ghana, we introduced the National Health Insurance Scheme.
And the telephone line, have him now. He is the secretary to NGOs in health here in the Upper East region. Good morning and welcome to Daybreak Upper.
Good morning, my brother, and good morning for having me.
Yes, I hope you're doing well.
By the grace, I'm good. And how are you and the listeners?
Not bad at all.
Right.
So last week, the president launched the free primary health care initiative, and he says that it is aimed at reducing or removing barriers, cost barriers, and also to expand access to health services across the country. As NGOs playing a major role in the healthcare delivery system within the country, and especially for us here in the Upper East region, would you be able to let us understand what you have observed with healthcare delivery, especially primary healthcare delivery in the region, before we get into the policies, sir?
All right. Good morning once again, and thank you for getting to discuss this issue too. Yes, in terms of health delivery in the region, I must say that Upper East is one of the poorest in the country, and then health coverage is very low. We have a high ratio of doctor to patient. We have high ratio of the nurses to the doctor, the patient. And even the last time I had discussions with the Regional Health Directorate, we are even made to understand that it is not even the numbers. It is now an issue of equity. So we have high numbers of nurses and doctors choosing to work in particular areas of their interest. You know, the region, we also have urban centers and then the rural areas. We have places people may want to go, and then those areas are congested, whereas the other rural areas lack professional health workers. So we will say it's all that good in the region when it comes to health delivery. It is not all that good.
But then the challenge that you just mentioned, were you able to get information with regards to what actually is attributing to that?
Well, I think this has to do with the posting of some, if I remember, 20-something health workers, doctors to the region, and most of them refused posting. So when we did our checks at the Regional Health Directorate, we were made to understand that one issue has to do with the insecurity nature of our region. Most of these workers were pointing to the fact that the region is not safe for them, and others could not even give a reason. But we dig further and also got to realize that some, because of the nature of our region, they consider our region as poor. So they wouldn't want to come here. They think that they may need for their families in terms of education, in terms of social amenities, they may not be able to get them in our region. So some also pointed fingers to those issues. Fortunately, I don't know what to say, unfortunately or fortunately, I would say fortunately, we were made to understand that most of these workers who refuse posting to our region, most of them also comes from, or they hail from parts of this country, northern part of Ghana. So it is an issue that I don't know how to coin it. And also, we had one of our sisters, I understand she's a Southerner, but she has wholeheartedly accepted posting to our region. I think she's in the Paga District Hospital. So anytime we are on air, we want to say kudos to her for accepting posting to our region, and even going to the rural areas. So these were some of the issues we were able to identify at the Regional Directorate.
Based on your knowledge, maybe you may be able to assist us to understand when we say primary health care, what exactly are we looking at within the healthcare system?
Okay, so when we're talking about primary health care, we are looking at health delivery that is community focused, and most importantly, we are looking at the prevention instead of the treatment or management.
Okay.
We primarily looking at the community focused prevention and then the essential health delivery. That that should ensure that every Ghanaian, especially those from the rural areas, have access to healthcare. And when we say access, we're talking about affordability, we're talking about equity, and we're talking about all-time run health service care at the rural areas, especially the rural folks.
So, what is your assessment of the policy that was announced by the president just last week? What do you make of it?
Well, we welcome the flagship project from the president and government of Ghana. To us, at a coalition, is a good initiative. We hope and pray that the thinking that went into it will see the full implementation of the policy. And then we also looking at the sustainability angle of it. It shouldn't be, in politics and in government, shouldn't be things mostly on paper or on the lips of politicians. But of course, it should be implemented to the letter. And then we also looking at the funding component of it. Government of Ghana, yes, we have limited resources, but of course, when we want to do things right and we get things doing right, then we can do them the way we want to do them. So funding should be considered. And then, of course, Upper East happens to be one of the regions, if I may say the first of the region to benefit from this community-centered healthcare system. We have the CHIPS compounds in the region, and kudos to Dr. Awuno. So when this initiative was mentioned, we realized that it is a game changer and is going to boost health delivery at the rural areas. We hope that they will take advantage of the existing structures at the community level to boost them, to give them the needed resources, to give them the needed training, the needed professionals, so that delivery of healthcare can get to the rural areas in the communities. So welcome the initiative, and we hope that it works to the best and then the full implementation of Ghanaians.
Patrick, like you were talking about sustainability and funding issues, what do you think could be done to actually ensure that there is enough funds to ensure that this particular project or initiative is implemented fully?
Well, I know the technocrats may have their way of thinking, but we at the rural areas would always want to see the low-hanging fruits. So we think that taxation has been one of the surest way of funding, but it depends on how incentive you are when you are taxing citizens and how accountable you are when you are taxing citizens. We've always maintained that some of the taxes can be converted. So recently, I don't know, I believe we still have the COVID-19 tax on our neck. So we ask, what is that tax for? Because COVID-19 is no more. Is it possible we convert some of these taxes and even many other taxes that government may think of to this primary health care or Muhammad care that they have introduced? And then another way is to, of course, the rural folks, when they see the results of their money or the resources they pump into it, when they are accounted, citizens will be very active in contributing. So at this assembly level, do we have initiatives that assembly can generate internal fund, push into this health delivery care, and of course the one holding the purse should be able to account to citizens. It could be a monthly, it could be a quarterly accounting forum, and then once citizens get to know, then of course they'll be ready to pay. So, well, these are two things that at the coalition level, if we have the chance, we can table before government to consider. But of course, like I said, the technocrats, as many as others, well-meaning Ghanaians, also may have other options that can be brought to the table for discussions.
As part of the policy, the government is making provisions for transport system too as well. And one of them is the tricycles that are going to be used and the motorbikes that are going to be used around. You think that this would help deliver healthcare services within our various rural areas?
Yes, I listened to the president, especially in the issue of the tricycle and then the the motorbike issue when he gave the example that northern Ghana, most of the health workers use motorbikes, and then up south there, most of them cannot use bikes, so they're giving tricycles, whereas northern Ghana will give them motorbike. And I think if you monitor the health system in Ghana, especially northern Ghana, some NGOs, I may not be able to mention the name of the NGOs offhand, but some NGOs and partners supported some health facilities with some type of tricycles to support in community outreaches. So it is workable. It has to do with maintaining the maintenance of these motorbikes or tricycles. So it is a good call. It will help in terms of moving from community to community, moving from rural area to another rural area. It will support a lot. But of course, like I said, we should also consider how to maintain them. The cost component of maintaining these tricycles and motorbikes should also be taken to consideration. But of course, I remember very well that I've been in some communities where our sisters and mothers in labor will not even get means of transport to the nearest health facilities. So when you have tricycles or motorbikes to support this health delivery, of course, the health workers may be able to reach out to these people in their various homes and provide the needed health care that they want.
Patrick, from where you sit and what you have been engaged in doing within our region here, especially with regards to your NGO works, do you think there are some structural challenges that could hamper this particular initiative that you want to highlight?
Of course. We key is our road network. The road infrastructure in the region is not the best. Though governments upon governments doing their best, but we still have a lot of poor road networks in the region. So key is that challenge. Secondly, we have seasonal issues.
Okay.
So linking that to the road networks, you can imagine a health professional on a motorbike on his way or her way to work, and the rain sets in. You can imagine what will happen. You may have to find a cover somewhere, and you now will have to determine when the rains will stop and how the weather will look for them to get back to their work. So that is two. Another challenge may even have to do with the infrastructure themselves. Recently, I have made some visits in Bongo, and we've seen some challenges with their facilities. We are just setting into the rainy season, and of course, already some of their facilities have already been ripped up by some windstorm. So, and I understand as part of the initiative is to look into these infrastructure issues to see how they can equip them or even build new ones if they need be. So these are some of the challenges I see. Also, Ghana Health Service works systematically. So I hope and pray that this needed logistics get to the grassroots, get to the facility that needs them. They do not sit in either the regional stores or district stores waiting for paperwork to be done, and the time they release them to get to the communities, these equipments may have lose their value. That is also a challenge that I will appeal to Ghana Health Service that as long as they receive them at the regional stores or wherever, they should try as much as possible to push them to the communities where their services are needed most, in time for them to be able to deliver the needed health care for our people.
Patrick, in your earlier submissions, you talked about accountability. And as NGOs interested in healthcare delivery within our region and the country at large, what role do you think you'll be playing to ensure that this project or initiative is implemented, and also ensure accountability to as well?
Yes, thank you so much for that wonderful question. I think as NGOs in health, we play the complementary role. We try our best to support government in healthcare delivery. So from the angle we sit, we will also do the monitoring. We'll see play our watchdog role to see that these initiatives they are implemented, and where there is the need to raise red flags, of course, the Ghana Health Service, especially in Upper East, we have good relationship with the health directorate and the health workers across the region. So where we think that we need to draw their attention to, we have to do that to ensure that the initiative is implemented fully. And I must say on record that we, from onset day one, we have been able to partner with the health service system in the region, and they listen to us, they take our feedback, and then we see the feedback in action. So when we say, oh, can we do this way, then we see that things are done that way. It means that they are really listening to us and they're implementing the feedback we are giving them. So we hope that this once again will be a lesson point for us. We'll all bring our issues to the table and address them when they need be. So I can assure you that we will play the role we are mandated as a complementing partner to ensure that we monitor, and then when we see issues that we need to advocate, we duly do that to the attention of Ghanaians.
Just help us understand, there are others who have fears that this particular initiative possibly is taking the place of the health insurance initiative. What do you make of it?
Absolutely no. From where I sit, I don't think it is taking the place of the health insurance, because my basic understanding is that primary health care at the community level, you don't need to have a health insurance card. All that you need is the Ghana card. But when you get to intensive care unit, whether it is the district health level region, or even at the point that you are being admitted, of course, the health insurance card will take cover. I rather see it as a supporting system to the health insurance, and I see it as reducing the burden of Ghanaians. So to me, it should rather be a complementary role to the health insurance, not taking the place of the health insurance. And I think that most Ghanaians, what we want is the universal health coverage to every Ghanaian. So both two will work together to ensure we attain the goal that we are all envisaging for.
Do you think there are some measures government can put in place to ensure quality healthcare delivery in this particular healthcare initiative?
Sorry, can you come again?
I'm asking whether you think there are some things that government can do to improve the quality healthcare delivery or maintain what we have currently, even with the increasing number of patients that we possibly record in our various facilities.
Sure. Government upon government doing their best, like I said earlier. There are still a lot that we need to do to ensure we get every Ghanaian covered. And we always say that, for instance, healthcare is the prevention is the basis. So and research have shown that when we take education, when we take sensitization, outreach is important, then we are reducing the burden of diseases in our communities. So though I am not all that grown, I know very well that in those days we didn't have the public health relation unit, and that is critical. So I will say that the public health unit, the public health promotion, I think they are doing a very good job. We need to ensure that we reach out to the community, the disease control unit, the public health unit, to take education and sensitization to the community. It is when the people at the community level get things right, then help begins from there. So we have a lot to do, and Ghana Health Service, they are doing a human job. I commend them for that, but I also think that when we do more of education, when we do more of sensitization, is mostly everywhere they say prevention is better than cure, and prevention is key. So I think it's important that we take education seriously. We'll be able to contribute greatly to the success in health delivery in the country.
All right. Thank you very much for joining us this morning to speak on this issue. We truly appreciate your time.
Thank you, and thank you for having me.
All right. So you heard Patrick Namo. Patrick Namo is secretary to NGOs in health here in the Upper East region. We just spoke to him about government initiative on free primary health care services. Is Daybreak Upper East 101.1 megahertz is the frequency modulation. We have a guest in our studio. I mentioned earlier that this morning we'll be engaging his good self, Professor David Miller. He's the president of Miller Open University here in the Upper East region. He's a renowned policy analyst and specialized in Greek and agro in the industry area. And also and some other issues that has to do with national interest to as well. We'll be doing that discussion this morning. So please don't touch your dial. To be locked here on A1 Radio 101.1 megahertz.
Abla junga mansuma katla nuarieni kate wale te kundare fanga Afrika te mala abla junga mansuma kate tare hakela kana ne dogenga kundare tona Today I tell you my people shine like the bright star in the skies cause there's a brand new day for the best to play Today I tell you my people shine like the bright morning sunlight Let the whole world know the future is bright. Africa, yeah, Africa, oh, mama. Oh, yeah. Oh, mama. Oh, yeah. Shine for me, mama.
So shine and make your place bright. Go out there and make a difference. Our good friend Samini is encouraging us to make our communities bright, brighten up our countries, brighten up Africa, and make Africa the best place to live in.
Today I tell you my people shine like the bright morning sun.
And so if you are shining like the bright morning sun, because you have some cash in your pocket, let me show you how to save this cash and make it cashless. Because this time around, we're promoting eCash. Yes. And Telecel is doing that for us this morning. So your money deserves the safest home for you. With Telecel Cash, you are protected every step of the way. No risk, no worries, no long stories. Just peace of mind. So you dial *10# or you download the Telecel Play app now for safe, secure transactions. Telecel Cash, the safer. Telecel Cash, send the keke. And if you have saved that money and you want to go into your building project, you want to complete that building project this year, please let me help you. So you get the best cement in town. Cement Papabi. Yes. And I'm talking about Savannah Diamond Cement. that you need to use for all your cement works, because Savannah Diamond cement is of high quality, it gives good results and after use, and yet it's also affordable across the country. Savannah Diamond cement works fast and also stands all weather conditions for many years. Savannah Diamond cement is a proud Ghanaian product from the Savannah Diamond Company Limited, located inside Bupe in the Savannah region. Savannah Diamond cement can be found in all cement shops in Ghana. Just ask Savannah Diamond cement when you go out there. Just ask for Savannah Diamond cement when you go out there to buy cement for yourself. You can also purchase in bulk at Savannah Diamond Cement in Bupe. You call them on 020-202-1175 or 050-155-6838. All right, so you're welcome back. We are going to have a conversation with our good friend. In fact, he's a friend of the media and a friend of the region. He's been doing good works for us, and we're still learning from him, tapping his knowledge and some of the issues that he shares around with us. Talking about the president of Miller Open University, and he's Professor David Miller. Good morning, and welcome to Daybreak Pies.
Good morning, and good morning to your cherished listeners.
Yes, hope you're doing well.
Yeah, I'm fine. Thank God.
Strong up and running. Yes, we love to see the energy in you all the time.
Oh,
yes,
thank God.
yes. So tell us, just before we get into some of the major issues, it's good we get your view on the current policy of the government, especially that has to do with the health care delivery in the country. And we just spoke to the Secretary to NGOs in health here in the Upper East region, and to get his views on it. He shared his opinions and how government could implement the policy and get results. The president's idea on free primary health care delivery. Professor Miller, what do you make of it?
Well, when I was driving in, I listened to Patrick. First, I saw the struggles you had with reaching him. This is just to show that I would really listen.
Interesting.
And he has done a good delivery of his stewardship as a secretary to a health institution. And the salient points have been captured in his submission. But there are a few key points that have not been touched that I would like to add, and I hope he's listening, so that when we meet somewhere we can discuss that.
Okay.
First of all, let's start on the subject of health delivery.
Okay.
And normally I combine health with sanitation.
Wow.
Health alone is just one component. So I combine again health and sanitation, and that's a departure even from the submission of the president.
Okay.
I think you have talked about health and sanitation, and that will make a lot more sense in the strategy. But I heard the Director General of Health Service, and he highlighted aspects of sanitation, but he didn't make it look like it's one of the policy sector. I'm saying health and sanitation because if you want to deal with those issues, the best strategy that I know as a development worker, the practitioner and also a professional, is to do preventive health.
Okay.
Rather than curative. In fact, a lot of people, there are some papers that indicate that curative health is a privilege, it's a societal thing. It's privileged people who normally go for curative health. The poor, the real poor, the best way to catch them is preventive health services, that which is delivered at the rural community. So if we lose that focus, or if we don't highlight that focus, you end up delivering a health service that is not universal.
Okay.
Yes, because I come from a village and I go there very often. They don't go to hospital or clinic until it's extremely critical. They have the chief compound. They rarely would go there until somebody lies there and is helpless. So if you have a strategy that forces the health delivery system to go to the beneficiary. Instead of the beneficiary mandatorily coming to the health delivery service, you've turned the strategy on its head. Because the current strategy, before what the president launched, gave the opportunity for them to sit there and want us to come. Unless there are vaccinations to be done or something. And when they go, they do the vaccine or collect whatever data and disappear. But this one, if the health practitioner is prepared in such a way that when he goes to the stakeholder in his home, he or she would add an aspect of education on sanitation.
Yeah, but this particular part seems to be part of it. The president mentioned it when during the launch, and they are even providing them with vehicles, like tricycles and motorbikes, for them to move closer to the.
Yes, and that's the newness.
Yes.
Now you don't sit in your health facility, and then today they haven't come, so you do your mobile phone or you get up and go and sell your tomatoes or whatever. You are supposed. But it has to be well structured.
Okay.
There should be like an inventory book, what we have log book. When you go, you log yourself and say which communities you've gone to, and log yourself out, and then go home. Such that somebody can do an empirical investigation. You go to the community to ask, this fellow says he came here. Did she really come? You see. So it is a system that is pushing health facilities out of the buildings into communities. That is, for me, turning the system on its head, what we know as at now. The second thing is that you go with a minimal diagnostic equipment. So you are able to sort of preempt certain situations that might occur later.
Okay.
By doing very simple tests. Don't make them look like they are doctors there and there. In any case, there's no payment for it. It's free. When you are putting these things in place, you are making health universally available. Whether a compound likes it or not, a nurse will come there. From there, then you do joint planning. The director mentioned it. You now plan programs with communities, with people at their homes, especially nutrition programs, sanitation programs, and then you can monitor the programs in your next visit. So you see how expansive that program can be. And the third, which is the most special, is that you build health data on individual citizens. And that is what is lacking. Except those of us who are privileged to go to the big hospitals. You have your folder, they can always monitor, when you start telling about new diseases, they will say, but Prof, these ones, how are they working? Are the drugs working? They are able to monitor. But there's nothing like that from the lower, the community level health delivery systems. So for me, those are three cardinal differences that would occur in a strategy like that, provided the strategy for implementation is there and the resource support is there. The other thing that happens is that there's now a critical or conscious link between a chief's compound, a polyclinic, or the higher level health facilities to the hospital. So that when there's a case, chief compounds first, the next level, I don't know what it is, then the polyclinics, before it gets to a hospital, maybe a district hospital, then a regional hospital. If you can afford it, you break the chain. You can bypass. You can't restrict people's health requirement. But the poor, the very poor, the communities where I come from, this is healthy. Then they are going, it's like their folder at the chief's compound is transferred to another health facility which is a bit higher, and the folder is already there. Okay. And like I say, what did my doctors do to me at this age? They go back to the folder. That folder enables you to go as far as the district level. Then they know where they could start the problem from. So you see how the strategy is the newness in it. Because I've heard people say there's nothing new. There's a lot new, provided the strategy for implementation captures these issues. So these are my preliminary remarks about this thing.
Yeah. So for you, how do we get things done? Looking at the current situation where you have distance health facilities vis-a-vis patients and people residing within a community. Sometimes people have to walk several distances before you get to health centers. What exactly should government be doing to ensure that this particular policy is implemented and curb the situation that we are currently facing?
Yeah, but this policy is saying the opposite. You go. I thought you were saying there were long distances for health workers, not sick people.
Okay.
Uh-huh.
So the health workers should rather go to.
They should go to the homes.
The homes.
And when I go home to my home village, I'll ask my family members, how many times has the health worker come to this house
Okay.
to talk about your health? Because he's now supposed to come. The training, the equipment, the logistics should enable her or him to come. So the long distance is sort of turned the other way around. It now becomes a long distance for a health worker. And therefore it should be well resourced, well remunerated, so that it can go the long distance. So the distance becomes shorter for the community.
Okay.
I just sit in my house. Maybe we schedule that tomorrow or market day, I'll come to your compound. You sit there and wait. You see. So these are the practical manifestations of the newness of this strategy.
I asked.
Let me quickly add that. It's like home visits.
Okay.
You know, in the advanced countries, healthcare is more on home delivery basis.
Okay.
You sit in your house, your doctor comes. He has a schedule. They will come and say, oh, let's go walk through your health situation today. Bring the previous records, you discuss. What, and then the things. That is what, and you pay for that. Now, a government is saying that should be free. And I hope the implementers understand this. For me, that is always the bane of our strategies. You see, that's the bane of our strategies.
You think the
and the motorbike, I hear people say, oh, it should all be tricycle. Look, I know a lot of villages around my village, tricycles is even a problem to get there, Motor Kings and so on. And in rainy season, they get stuck. Motorbike, bicycle works. They are the best means to reach the so-called remote areas. They are not talking about privileged communities.
Okay.
For me, Bolga is one privileged one, you see. I might go to, I don't know where, you people, the whole Upper East is like one big city. You don't have villages anymore, you see. Because if you go to some typical villages, and you can find them in regions with very large spans of land, like in Upper West. I can mention a village like Vene. It's a village under my village. How are you going to reach there?
Okay.
Unless a motorbike. Bicycle. Tricycles can be a backup in areas where motorcycles are most necessary.
Those who are actually talking about the bike, the tricycle is concerned about the nature of our weather.
Oh, what about it? No, it's not new. That one is not new. NGOs that are into health and sanitation provide motorbikes. We go and see nutrition and community workers. When they go to the office report, they put their sack behind them and go. And I've never heard any of them say, oh, it's now rainy season, I can't go with my motorbike, so bring me a pickup. I've never heard it.
Okay.
So people are just trying to empathize, to put themselves in the shoes of the fellow and complain.
So I asked Patrick about issue regarding structural challenges, and he talked about road network. Do you also share a similar view, or you have some other challenges that you would want to talk about regards to the implementation of this particular initiative?
Well, he captured all the structural issues, in my view. But if you're talking about road network, what type of vehicle are you linking? You have to link poor road to the type of vehicle. Bicycle, what is the poor road network there? Motorbike, what is the poor road network there? It's when you go to the bigger vehicles, means of transport, then you can leverage road network.
Bad roads also damages motorbikes early. You get to some areas and actually the road is not more trouble at all.
Exactly.
Very rocky and stony,
That is
potholes here and there.
Yeah.
These,
But that's precisely what I'm saying. Make sure the logistics are there. If you say you are going to change motorbikes every year,
okay. So it will be deliberate.
deliberate, affirmative action every year. Those in rural area, your motorbikes will be changed, spoiled or not spoiled. And if you go to countries that have this primary health care, I've gone to India and I've seen it. They change, it's a routine change of set of tools. So you even go to a health center, they have 3 or 4 motorbikes. Like even the political parties have done it with their assemblymen and their faction. I have a brother who has gotten 3 motorbikes. Not that he requested. He has one he's using. The party thinks that he needs another one. They replace it. You see. So make sure their equipment is routinely renewed. And the compensation for all this movement is there. It's not one that will run 3 months and after that there's a problem and everybody starts shouting. So I think that it is a policy worth pursuing. And all these bottlenecks, let's roll it out. We'll cross them one by one at worst. Otherwise, I don't see them as problems at all.
So there's everything new about this this policy.
No, the newness is in the redirecting the existing, because the CHIM compounds exist, and the CHIM compounds were supposed to be compounds for planning community health delivery. That's the meaning of CHIPS. You see, but they tend to also do secondary or curative health and left out the primary health. So they will sit down and they wait for people to come, they will check them and do this, and then they close and go home. So by default, the CHIPS compound became like referral centers or hospital centers. But if they were going, you go to a CHIPS compound, it's likely you might not meet all the workers, you get only 1 or 2 people, because the rest are in the field, monitoring, preparing people, advising them, educating them, dealing with sanitation issues as well.
So, in a nutshell, you think that this particular policy will bring a relief to rural folks who possibly find it difficult more often to get to health centers for treatment or for healthcare services?
Yeah, I think Patrick mentioned that, and I agree with him. But added to that, you know, there are some disease conditions that unless you go to the person, he won't come and tell you he has it.
Okay.
2 major ones: drug abuse, alcohol. Who is coming to walk to a clinic and say, "Oh, I've been taking what is it called? Red or what? Red or any of the disease, and it's disturbing me." Nobody will do that. Or who will come to you and say, "Oh, I've been smoking weed, and the weed is giving me sleepless night." Who is coming to do that? Yeah, drug, alcohol. Oh, I drink too much application. But when you go to the families, you'll be able to identify. You go there early in the morning, somebody is booze. Then you go one day in the afternoon, he's still booze. In the evening, he's booze. You just say, "Oh, the way you are going at this thing, moderate it." First, you ask him, "Have you eaten before doing this?" You say no. And then you start there. You are keeping the fellow away from a hospital. All the hypertension and diabetes, you are the same for alcohol. And the youth in drugs and alcohol, unless a program of this nature occurs, they are not going to walk to any hospital and say that they are in drugs or alcohol. They won't do that. Nobody will do it, you see. So that other component should be mentioned.
Okay.
And those are the diseases that we should be worried about.
All right.
They are the ones that will kill him.
We're making an effort to speak to Andrew Satarowini. He is the former Deputy Communications Director for the New Patriotic Party here in the Upper East region. But whilst we make effort to get him online to speak to him on this particular issue, because the opposition have been talking about this, and we want to get their views too on it. What do you just mentioned something in regards to drug abuse? It's something that is rampant within this part of the region. What have been your observation, and what do you make of it?
If you don't start battling it, confronting it, it's going to be a disaster. It's going to be a disaster, collective disaster. Now we are looking at it as if it's individuals who are into these drugs. But some of these individuals are in work situations. They drive cars. They go to the office. And some even work in hospitals. They administer drugs and so on and so forth. You are compounding the issue unless we tackle it as a societal concern and work at it. And also, you've left out the alcohol, but for me, Upper East, one of their serious problems is alcohol. It's not same in Upper West.
You are not part. Are you not part of it?
No, I mean, so it's very difficult to know where I belong. You see, because of the pito drinking in Upper West, they take less of those things, unless there's funeral or something like that. But you people have run away from your pito, and you think that the only drink is something else. So that is the cause of the worry. But before he comes in, I think the issue of financing should also be discussed.
Okay.
Yes.
Yeah.
Because what you are doing now will be more expensive at the community level and maybe less expensive at the higher health facility level. Because fewer people will be going to hospital and their histories, medical history and those things will be known. For me, I've stopped being sympathetic to Ghana as a country that doesn't have resources. I've stopped.
Why?
Because we have. This transition of government has demonstrated that we have. It's greed and lack of accountability and milking the system. We have. And that's why I think this government, when it says it's going to do something, it has already. It's like a blind man going to throw a stone at you. His foot is already on the stone and he's talking to you. Because the money, look, I did a study first time on judgment debt. Compared it to the development sector budget for health, education, and agri. And the payment for judgment debt was more than those three sectors combined. Judgment debt, you see. And judgment debt is more legitimate way of looting. But the illegal means of looting were more than procurement breaches and all. I didn't go there. I only did judgment debt. And it was in collaboration with the PhD student. He's graduated and he's an auditor. He's graduated.
Okay.
When I presented it in Kumasi, Park Wisdom was there. He was shocked.
Wow. And
judgment debt, most of it is colluded. The legal systems that are to fight it will encourage you to slap the judgment debt, and they will renege in their prosecutorial positions, and then you earn a reward. Then you get paid, then you give them their cut. You see. So a lot of people who get up there are shocked about how much wealth the country has and how much leakages that occur in that system.
All right.
And they think the international community doesn't know this. They know.
Yeah,
they know. They know how rich we are. They know. And they know what we do with our monies. So I'm no more sympathetic with government saying that there's no money for it. Especially, like I said, for this regime. When they say we are going to do this, it means they have started far away. They are not the ones who are going to say it and now start searching. Maybe they will be searching for supplement.
You have some examples to share?
I don't want to start digging into data, but you can perceive from their actions, from their style. When they said they were going to allow Get Fund to operate, they knew where to, and everybody asked where are they going to get the money. They did it. When they said they will give DC assemblies 80% of their funding, people are wondering, how are you going to survive? They did it. When this big push team, how are you going to manage? They did it, you see. So, and it's good for governance. It's setting the standards for the future, such that any other government that comes into power will expect them to be this type of, to adopt this type of strategy. Don't bring a policy when you haven't looked for the resources. Try to build the resources, then, you know, they started by saying they won't do all districts. They'll do 150. So you see the thinking that goes into strategy. So it means maybe the 150th money is guaranteed. So when they started, they will now start looking for the other. That's my perception. I'm not speaking for government.
All right. All right.
As a development planner, this is how I see it.
You see things. All right.
And that's good for development planning.
Okay. We still making effort to get in touch with Andrew Satarowini. But whilst we are at that, let's look at the issue regarding tomato production in the country, something that government have actually shown concern and made us to understand that the issue is critical and that policies have to be put in place to arrest the situation. Recently, we were hit by the exportation ban from Burkina Faso, and that have been lifted. But then, what our plans would be to ensure that farmers are engaged in cultivating tomatoes to supply the country is what we are still battling with. Currently, we understand the government is making an effort to close this gap, and they're looking for funding across in some parts of the world. You have privy to some of these issues. You are privy to some of these issues. You just wanted to put it on bare for us to understand what the challenge has been with regards to tomatoes production here in the Upper East region and Ghana at large, and what government is doing currently. What you make of it?
Yeah, this is where I'll be hard on government. Because I think we all have seen the problem, but in a hurry to find a certain solution, they are not being informed by institutional memory or by history. By now, the government should have sent a delegation to come to Upper East and sit with some of us who did the tomatoes extension services to such a level that Burkina used to buy from us and to get everything from us. None. And we don't only used to do the extension or give the knowledge. We are also tomato farmers.
Okay.
Yes, not just 79. We are farming tomatoes. Now, the solution seems to, the impression I get is that the solution sits in Accra or sits in the south. And the experience is here. Come and find out from the various stakeholders and try to do what we call a generational analysis. There are those of us who are 70 plus who were here and did tomato farming.
Okay.
Then some joined from 50 to the 70 who are relatively, then the youth that are currently doing it. Do a generational analysis of why the tomato industry suffered the way it did. That will provide with more information. You see? Because fundamentally, government assumes that a certain blueprint on tomato salvaging would work. And I say no.
All right. Prof, hold your fire for now.
Okay.
So we get on the phone lines and speak to our good friend Andrew Satarowini. He's a former Deputy Communications Director for the New Patriotic Party here in the Upper East region. We just want to get his views on this the issue that we talked about initially with regards to the free primary health care initiative by this current administration. Good morning and welcome to Daybreak Upper East, Andrews.
Good morning.
Hope you're doing well.
I'm very well. Thank you for having me. It's been a while.
Yeah, it's been a while. Let's get your views on this particular development from the opposition point of view. How do you assess the free primary health care initiative? Is it something that you would say is a credible policy or more of a political promise?
Well, I would want to speak to this as a Ghanaian more than speaking to it even as a politician. To the extent that I think that the policy is a laudable idea. And if you look at the intention behind it and the history for which, the history of our health service delivery in this country prior to the introduction of the National Health Insurance in 2003, and the later modification of the Act, of 2003, Act 650, in 2012, to make sure that the policy, the National Health Insurance policy is a bit more robust, credible, and a bit expansive. Based on that history, you would appreciate that an introduction of a policy that seeks to deal with the preventive aspect of the effort that engineered or that brought about national health insurance existence is nothing short of credible. Very, very credible and very, very laudable. Because if you look at the money, the colossal sums of money we spend every year, paying for claims, of curative services that is being offered or being rendered, then you would understand that if you were to look at how to reduce that flow of people that will get sick before they go to seek that medical attention, then it is the smartest move. So that, Mr. Wakili, if you have some slight headache or you can just get up, maybe there are some diseases that may not give you early symptoms unless you have checked. And for the fact that you can have that access to check, early detection, and all of that, you are going to be able to stem, or to help government reduce expenditure as far as paying for claims is concerned. So for me, it is a laudable policy. Let's not do politics with this particular policy. Let's focus on how it affects Ghanaians and look at the debate rather on the quality, the debate on fishing out miscreants who would misrepresent, especially those at the service delivery points, who would want to, turn this policy around for their personal benefit, either than the public good that we are seeking. That is what should be the center of the communication about this policy, if you were to ask my view.
Great. Andrews, you happen to work with the National Health Insurance Authority, and I want you to help us understand the system, or say the policy of the National Health Insurance and that of the new free primary healthcare initiative that this government have just brought in. What is the linkage? Where are the differences that you would want to point out?
Great. The linkage is simple. The National Health Insurance Authority, I don't want to bore your audience with when it was established and all of that. But I want to say that the critical problem that used to exist in Ghana was that if you didn't have money in your pocket, you didn't dare go look for healthcare in any facility. And so if money was a challenge, people were resorting to all manner of quack means in seeking healthcare, which did not help. So the WHO, classified Ghana along some, global southern countries as countries that really didn't have a robust healthcare system. So it was a requirement in a policy objective, a global policy objective in the Millennium Development Goals at the time. And based on that, we decided as a country to move towards the mutual health insurance system that we had done. Later, we made it a national health insurance system. What the services of that system was that if you were sick, you take, and you are a registered person, you take the card, go to hospital, and based on the little premium, an annual premium you have paid, the thing started with some 7 cedis that you need to pay around 2012, you're paying around 7 cedis. Now you need to pay about 25 cedis or 23 cedis, depending on the southern sector, pays just about 1-2 cedis higher than the northern sector. You pay that 1 year premium, and then based on that, your card is valid for a whole year. And if you were sick, you are down with ailment in this case. It is not as though you are suspected, but when you are down with ailment and you go to the hospital, you are treated free of charge, and for that matter, money not being in your pocket is no more a barrier. The difference with this is that now we were serving only those who were registered with health insurance and had paid premium or were qualified to hold. We have some of the groups that don't pay premium. Pregnant women don't pay premium. Children, those who are with SNP, they don't pay premiums. And we have those that we also call the vulnerable groups, the LEAP people, the indigents, those categories, very poor in our society, they don't pay premium. They get free registration. I think about 65% of our population don't pay premium for health insurance. So you can imagine how enormous and colossal the budgeting of that particular sector of population will be. Now, with the free primary health care, if you have a Ghana card, which is not a national health insurance card, which means that you are not a registered member of the national health insurance card, you are still able to access that particular service because we think that the entirety of the population, we want to reach what we call universal health coverage, meaning that at least 80 to 90% of our population should have access to healthcare without any hindrance. So the click here is that you don't need necessarily to have a health insurance card. That doesn't mean that we are saying people can now relax and should not register onto the scheme. No, we are saying that at the time you want to access the service, you can use your Ghana card, and once you are identified as a Ghanaian holding the Ghana card, you can be attended to, and then you'll be encouraged to go and enroll onto the National Health Insurance card. This is the catch. Number two, now you are going to seek for preventive care. You are going to assess yourself. I just walk into a facility and I'm going to assess myself to check whether my system is well, my liver running well, my liver is it functioning well, my kidney is good, is my temperature good. You check that. That is to help you know that I am in good shape. The previous or the system that is currently running is that you must be sick and you have to go to a hospital and then you have to go through a curative process where they will seek to be treating you. So this is the small linkage, but a complementary service that is going to help us, attend to the health needs of the Ghanaian people.
We had an earlier interview with NGOs in health, and their secretary spoke to us, Patrick Namo, and he has concerns with regards to funding. I don't want to get from you, from where you sit. Do you equally have those kind of concerns with regards to the capacity of government to sustain this particular initiative by way of funding it?
I don't think that funding should be an issue. The problem in this country concerning national health insurance and its, let me use this word, allied services, is not about the funding. It is about the independence of the authority. If our funds that we aggregate, right, from SNP contributors, from, the levy that you pay when you buy public goods, you have a 2.5 levy that you pay for health insurance. People buy light, they pay for those levies and all of that. So when you aggregate all of that, the money that comes to us, trust me, if the national health insurance would be allowed the free will to be able to utilize that money solely in that sector, I am pretty sure we are going to be able to be okay with in terms of budget. And remember, we also get some funding, abroad. There are countries that even the WHO and then USAID at the time, all of them used to find a way to contribute to the services that we render. So budgeting is not, or funding is not really the problem. It is about prudence. It's about governments over the period taking their hands off. The ex-Wild government, for instance, came and decided to put a cap in, saying that you cannot spend beyond this. So if, for instance, a particular period, you had enormous claims to pay, and those claims, warranted that you go to a certain level, which maybe our budget or our fund, our money will be able to do because of the policy of government that you didn't need to exceed a certain amount. You couldn't do that. But this particular government has taken the cap away. Now you can look at it that there is some level of leverage for the authority to be able to function more. If we can allow, I know they are also trying to touch our money, but if they can allow the National Health Insurance Authority to have its money on its own, and then prudent expenditures are done, that's what I'm saying, that the Ghanaian people should be concerned about whether we are spending prudently regarding this. If only that can be done, trust me, we don't have a problem with funding.
Right. From where you say, do you foresee or envisage any challenge in implementing this policy that you want to highlight this morning?
What I'm already seeing is that it appears there is a certain mislink in the communication. People think it is a whole new program. It is for want of a better way, it's an addendum, it's an addition to the services that we render. It is a way to expand the access. So the strategy is that you want people to come and access the service who are, holding your card. Now, these people, until they are sick, they don't come. And when they are sick and they come, it aggregates a certain colossal sums for you to pay.
Okay.
And it's an X number. You are looking at how do I expand that X number from the 50% of or 65% of the population that we have to, let's say, about 80% of the population. That is where primary health care is a strategic game changer, so that with the Ghana card, we can rope in a lot more people in it, so that because it is not that you are until you are sick, you are able to come in, people are able to access the service, and by that doing, we can be sure that about 80% of our population know their health status, know the challenges they are dealing with, and are very precise in the kind of treatment or health care that they need. That will help us from the mystery, the shopping, health, you can call, I don't know whether you call it mystery shopping or whatever the right term. People just go around shopping around health. They go here, they say they treat them for headache. Tomorrow they have knee problem, they go there. If they know that all these things you are facing is because you have some diabetes, then this treatment is direct on diabetes, and it doesn't allow us to be spending money on A, B, C, D about you when you are going around, the facilities and all of that. So yes, it is an addition, and I don't see, the only problem is, of course, the politics will happen, and politicians always have to have, if I'm wearing a different cap today, maybe I would want to say one or two things, but that is not exactly what it is. Trust me, it's a good policy. Let's why are you laughing? It's a good policy, and we must support it. Honestly, it's a very good policy, and we must support it. And look, I'm telling you that in the world, in Africa, for instance, Ghana's national health insurance policy, it is a model. A lot of Gambia is studying us as I speak. Kenya has crawled from Eastern Africa, coming to check to see how we are doing it. Nigeria is struggling, the biggest country in this, West Africa, are struggling to find a workable one that it is only in Ghana. And now I am interested even in my thesis that I'm looking at how can we begin to port. If you remember Haruna Idrisu's time, he has something we call portability of SIMs. You can port a particular SIM onto another, right? I'm looking at how can we port the national health insurance card of Ghana across all the, now the 12 West African countries, so that if I am sick and I'm in Nigeria with my national health insurance card, I should be able to, access healthcare. Yeah. So it is a very good policy and an institution that if we can do away with the politics, if we can do away with the negative communication, trust me, and look at how the impact of it on the the Ghanaian population, trust me, we should be going and doing something good for this country in terms of our health.
Andrews Ataroni, thank you very much for joining us this morning. But then on your thesis, well, if you are done with it, kindly share with us. We would actually want to discuss that.
Of course, sure, yes, I will. I will.
Yeah. Thank you very much. You truly appreciate your time this morning.
Sure. All right. I was grateful.
Okay. So you heard Andrews Ataroni. He's a former deputy communications director for the New Patriotic Party here in the Upper East region, and he joined us to add his views on the current issue of free primary health care initiative. Prof. You heard him.
Yeah, I must commend Andrew. The way he's treated the subject. It's not often that you get this in the national discourse in terms of development issues. And if things were that way, the country would be better off than just say once it comes from you, it has to be bad. The only thing I want to add is that it's not a new policy, which he has said, but it's not an expansion of the existing policy. It is a re-engineering of the existing policy.
Hey.
Yes. It's one of strategy. I didn't list them. I said number one, instead of chiefs compounds sitting in chiefs compounds have to move to communities, to individuals, to households. Does that exist? No. So that is one element of re-engineering. The number two is the emphasis of sanitation and the identification of disease situations in situ in the people's surroundings. I mentioned drug and this and that. Don't come and report that. When you go to, you see how neat a house is, you can mention that. So that is also the newness of it. Number three, he mentioned it, but he didn't say it was new. Your record, your health records are very, very critical.
Okay.
You see, he's now trying to do a PhD.
Yeah.
And for me, if I'm supervising the PhD, he has to indicate beforehand that type of record consistency of a patient that can be monitored and used for higher decisions does not exist.
Okay.
That's why you should query. If you say it exists, I say, then why do you want to share it around the whole West Africa? You see. So you query the status quo. The policy might be the same,
All right.
but the strategy for implementation can be queried.
Okay.
And that's what we are querying.
All right. Thank you very much. So
But he said something that was very good too.
What is
He
that?
agrees with me that money shouldn't be the issue.
yeah, fantastic. That is true.
And this is, and you are perfect. This one, I would like to supervise your work. Money shouldn't be an issue. If people will just hands off and let the money do what they are supposed to do, and don't put it in their pocket and go and sit somewhere with it. Yeah.
All right. Thank you very much. Let's get onto the phone lines and speak to one of our good friends too as well. He's a former national president of Peasant Farmers Association, Abdul Rahman Mohammed. He's on the phone lines with us. Good morning and welcome to Daybreak Up, sir.
Good morning, my brother.
Yes, I hope you're doing well.
I'm doing well by His grace, and you?
Not bad at all.
Good.
Yes.
Good.
You and your colleague farmers have had concerns with regards to tomato production in the country, especially the northern part of Ghana. And currently, government has a new plan to augment this particular situation and actually ease the burden on those of us who actually consume the product by producing tomatoes in large quantity. This particular initiative, what do you know about it, and what do you make of it entirely?
First of all, let me thank you so much for engaging me. I'm very, very happy, and I appreciate your engagement.
All right.
And to go ahead, I was part of those who initiated that inside of government sending people to Burkina to go and negotiate Burkinabés to allow tomatoes to come to Ghana. While there are tomato farmers or farmers in general in Ghana, why can't you just promote Ghanaian farmers to produce locally so that, you may not go there and then waste monies again and energy and time to go and discuss there. What if you go and it backfires? You can go there and negotiate and the people will say no. Or because they don't want to give you, they'll give you a big task and you have to go about that. Meanwhile, we have farmers who can produce. So I was part of those who initiated that, engaging government that no, we don't want that. We think that the best way is to promote your farmers in the country to produce it locally. That's what I know about the tomatoes issue.
All right. So there have been concerns with regards to the mention of some areas in the country that is going to be the hub of production producing tomatoes, and that has to do with the place like Afram Plains that the vice president mentioned while she is in Spain looking for funding for this particular initiative.
Yeah, so I think that if you look at that, I may not go deep to talk about that one because as a minister, I think maybe he might have drawn his plan and maybe he might have gone around the country. I don't know whether he has been able to reach to us in the Upper East region to see whether we fit for that or it is rather a farm place that fit for it. So based on that, I don't want to talk much. But what I know is that I know that we are sharing borders with Burkina.
Okay.
And we have learned a lot from Burkina. Burkina also learned a lot from us. So if government is thinking that there is some initiative like that, they should rather push half of it to the northern region or the Upper East region including the northern sector, so that we will be able to use our knowledge that we have acquired from Burkina to produce, than to go to other places and then, you see, any business that you want to be and then succeed, you must have the knowledge of that business. And I think that we have acquired knowledge from Burkina Faso in terms of tomato production. When you go to Navrongo, they produce tomatoes. We produce it is because our farmers are not supported, heavily supported. They cannot extend it to make sure that we are able to feed the country. But this time we are looking at what measures can we put to ensure that we are also self-sufficient in tomato production. And that is, I think that, the minister has to have a second look at it. And even if they think that a farm place is good, why not also try Upper East region and see what is good? Because Upper East region is already producing. We're already producing. So all what we need is to give us the capacity, give us the support, and then we'll go ahead. That's all.
With regards to knowledge base, some argue that even the Burkinabe we're referring to learned it from us here.
Yeah, so that's what I don't want to say. Because if government didn't recognize our knowledge and think that it is good for them to follow up to Burkina, then let's even use it that way.
Okay.
Even if it is that we have learned it there, we have acquired the knowledge.
Okay.
You are speaking to me English, it's because I went to school. Do you know my language? Maybe if you were to speak my language, you will understand me.
Yes, that's true.
So we have learned a lot in terms of, tomatoes production. And I think that government should just support us. We have already have a factory. Don't we have a tomatoes factory? Which government should have used that one to ensure that we produce enough of tomatoes. That is what the Burkinabés are doing. They don't. It's not that they have land more than us. It's not that they have water more than us. It's not that they have. The farmers more than us. We also have everything.
Okay. Do we have the capacity, from where you sit, knowing who your farmers, where your members, you are the former president, knowing who the number of the farmers that we have within our area here, whether we have the capacity and the land to actually cultivate tomatoes in large quantities to feed the country and even export?
I want to assure you that, look, Ghanaian farmers, we have the farmers, and we have people who have the capacity. Let me tell you something. If we go back to rice production, initially people were saying that, Ghana, if we want to produce rice, we produce rice just the past 3 years. Rice is fully, on our warehouses, and we can't even consume it. We can't consume it. So the only thing to do is to try the people and see whether they have the capacity. But is it not government's responsibility to ensure that the farmer who is not having the capacity should have the capacity? Okay. It is their responsibility to do that.
Okay.
Yeah.
So we would have to wrap up our conversation with you. What would be your word to government and the Minister of Agri currently making effort to start this project?
Yeah, I want to appeal to the minister that, look, we are not arguing the fact that a farm place is there, but he should also come to our aid in the Upper East region to ensure that already we have the tomato factory here. It was not by incident that they brought it. It was because of the production. So it is just for them to top up and bring it up so that we produce it and feed it.
All right.
You see the point? We will be able to produce. It's just that our farmers are not taken care of.
All right.
If we take care of them, assure them with a ready market, and then we will do as what they are doing. Burkinabés are doing, even more than what they are doing.
Okay. All right. Thank you very much, Abdul Rahman, for speaking to us this morning.
You're welcome. Thank you, sir.
Okay. So that is it. You heard our good friend Abdul Rahman Mohammed. He's a former national president for Peasant Farmers Association of Ghana. Prof,
Yeah.
You heard our good friend talk to us on the issues that you have raised.
Yes.
Yes.
He's captured most of the issues and also the concern that Upper East should be the starting point because the knowledge, skill, and experience is there, and the potential is still there. But just a bit of explanation. The reasons for going to lobby in Burkina was not to make it a permanent solution.
Okay.
Because if you have lack of tomatoes in your country, and he's suggesting that you support the farmers to produce, that means 4 months down the road, or 3 months down the road. So between the month 0 and month 3, what should happen? So it's a stopgap measure. And Burkina saw that. They allowed some to come. But on the understanding that after that, you don't come after your 4 months again and then come and tell us that, give us or allow us to take tomatoes. So that was basically the strategy. It wasn't to just replace the entire thing. So it was just the immediate happening, the today, and then maybe a few months, and that's all.
So from our requirement for tomatoes in the country, I understand we are the estimates are around 800,000 metric tons annually, and what we currently do is to about 500,000 metric tons that we are able to produce. The rest we import.
Yeah, I said it here before that at the time that Upper East was leading in tomato production, it was tomatoes.
Okay,
that's why it's called Tomatoes Factory. Palugu Factory is tomato factory. When the farmers realized that they were not being supported, they diversified. So the same tomato farmers, some have gone purely to pepper. They don't produce tomatoes again because they are not able to sell and all the other reasons. Some have gone to eggplant, garden eggs, and so on and so forth. These are the 3 major crops. So if we do an analysis of the vegetable supply system from Upper East, the highest will be pepper. It's not tomatoes. And the eggplant, the garden egg, and all the trawa and all those things will be second. Tomatoes is third. Not because the potential is not there, but because of a production substitution based on clear thinking of farmers. So if you want to capture the areas produced by pepper and add it to tomatoes, and take the areas produced by garden eggs and add it to tomatoes, you will get more than the 800 metric tons of tomatoes.
Okay.
It was on the basis of that we redesigned the Palugu Tomato Factory. The investor saw the information is clear. You can get more than the 800,000 metric tons of tomatoes. But because of this default, that farmers have diversified. Even the investor says, well, if this is farmers' rationale, I wouldn't force everywhere to produce tomatoes. Some will still produce their pepper, some will produce tomatoes, some will produce the eggplant, the garden egg. I would pick all and can it and process and do value addition. And that makes the argument stronger for not limiting it to a farm place. So that some will come from here, like the last speaker said, and some will come from there. In any case, the tomato variety responds differently to environmental factors.
Okay.
The dry season, the high temperature that we are experiencing now, if you combine it with the moisture and water, you get a different yield potential when you have a smooth, soft climate. And the farmers know this. That's why the upper regions or the northern Ghana is suitable for dry season vegetable production. You produce a different taste of vegetable.
Okay.
It's just like yams. You can produce yams nearly everywhere. They won't taste the same. Kindabo people produce yams. They will say the Bimbla yam is better or the Panda yam is better. Taste is different because the sugar concentration or the juice concentration is different. So why not emphasize the north, produce the dry season one, then Afram Place can do the rainy season. For all you know, the rainy season one might end up to be more watery, more soft, and so on and so forth. And it might not be good for all the consumption factors that you require tomatoes to do.
Okay.
So now you sit down with another large production of tomatoes from a farm place, and then you don't know who is buying it. Then you end up with a problem. So multiple locational what I call production of agricultural systems is the in thing. That is what to do now. So we are only pleading with government, and he is with Peasant Farmers Association. Make a strong argument. Even if it is captured in the design, make sure it is captured in the design. Don't assume. And that's what advocacy is. Just say, okay, these are strong ideas. If you have it already, just show me that it is there already. If you don't have it, please pay attention to this. We don't have to sit down and let it happen. Then we start crying wolf, you see. So that's why I think the Peasant Farmer Association, all those associations, make sure it is there. If the minister or the vice president says it's already there and they show you evidence of it, fine. But from what we heard from public communication with the donor country was a front place. You see.
Why should we be worried? As someone may ask, is there a need for us to be worried about this?
That
it was mentioned that from planes.
No, we wanted to say, well, she started in Ghana, which is fine. But if you have the money and things you want, a front place, we said no. You don't start it like that. In fact, if you should, by default, you should have said, the North is there. They have a lot of experience with this. The last speaker said he cannot vouch for the fact that Burkina learned from us. I can tell him for sure that 79, when I was an agri officer working here in extension services, we taught Burkinabe how to make tomatoes.
Okay.
We taught them. And they used to take their supplies from here, for sure. And fortunately, yesterday, without knowing this, I went to another colleague of mine who is as old as me. And he was talking about when we used to produce tomatoes. The same Burkina story. So people are still there who knew that we sent this message to Burkina. Now, the thing Burkina is doing, which we never did, was to have small ponds of production systems. We believe in this large-scale irrigation system. They just dig a small, round, like a well, and then put organic matter and this and this. And that collective potential put together is now so high that it requires a factory. So it's not so much just tomato production. They've added, like what we are doing with the primary healthcare strategy, they've added a component to it. So you can get thousands of farmers producing just small portions. We are still not used to that. We are used to having an irrigation dam and canals, and then we have to have pumping machine and this thing. But that's not what they are doing. They are doing that in addition to this strategy.
What do you think farmers should be doing currently to prepare ourselves for this project, if actually we get portion of it here in the Upper East region or part of the northern part of Ghana?
The first thing is what we call farmer-to-farmer exchanges. You have to send an association or a group of tomato factors to go to Burkina and sit with the farmers there and discuss tomato production. That one is not in the classroom. It's not in the textbook. When they sit down one-on-one, unfortunately the languages are similar across the two countries. They'll have a conversation. They will learn the nuances. They'll even now see that, besides this irrigation dams and so on and so forth, we can make these ponds and then small this and still produce tomatoes.
Okay.
So that should be a starting point. A farmer, an excursion of farmers who are into tomato production, especially the youth who are now more active than the elderly in the tomato. Send them there. A week or two, they'll converse, mix with the distance. They come back with the experience. Once the support is guaranteed, they start from there. See, what can we do with what we have now? Then if there are new varieties to add, we add. And I tell you that when you do farmer-to-farmer exchanges, whether you like it or not, they'll bring seeds back. They'll bring seeds from Burkina. We the Buklon people who want to hold on to our nature and say, no. They will bring it back. With plant quarantine or whatever, they will still bring seed back. And for all you know, you start seeing that variety in the system. You now regulate and now put in your measures for increasing productivity. Then a farm place that the Vice P has mentioned could go for the large-scale dam, whatever. Then the northern part will combine the existing dams, rehabilitated, with these small individual farmer production systems.
Okay.
So it means we have picked Burkina's experience, but we still maintain our own experience, which is also useful for the production system. And in fact, that was what we were going to do with Palu.
Okay.
Yes, the redesign was like that.
One of you have in-depth knowledge about our land tenure system here in the northern part of Ghana, let me say, because of the places that you have moved around in. Do you think that land would be an issue when it comes to acquiring land for such kind of projects?
The individual ones, no. And that's how Burkina got very successful. It's my own land. And I make a small pond. It's not a hollow. It's like a bath. You plant the things there, you put organic manure and so on. You water it with just a bucket of water. They don't go more than that.
Okay.
Yeah, because they don't have water there like us even here. You see? The individual ones, the fellow is doing it on his own land. It is this mass production that, and I can now begin to sympathize with the choice of Afram Plains. They think that land there is easier to acquire without headaches. I don't know that very well, so I wouldn't go for that argument. But then there is a large irrigation dam that gives the problem. You know, Upper West is not very successful with irrigation agriculture.
Okay.
Because immediately they built the dam, and there was a contractor who was doing a road. Most of the dams they built, P&W Ghanem, he built most of them. They are not being used. Because of this land, you finish, now the owners of the land will show up. And they are not in vegetable production. They now want to be selling and tell you what to buy and what to plant and what not to plant.
Okay.
So that has, but the upper east here, fortunately, Tono and Via are there. And, you know, there are portions not registered of Tono and Via that farmers use for tomato production. That's what they call the jungle lands.
Okay.
Yes. And for all you know, they are bigger than even the irrigable area. So you can systematize this, register it, make it an identifiable production niche.
All right.
And then support them to produce. When you do that, you'll be answering to many things. And like I said, don't underwrite or water down the other vegetables, the pepper and the eggplant and so on. If you do that, you will end up with another problem. Someone, oh, we don't have sufficient pepper in the system. Then you say, how do I do pepper? One thing I know, yesterday again, I went to a colleague in Navrongo. He's also retired, and we're talking. One thing he's telling me is that because of the enhanced road between Tumu and Bolga, market days, the trucks come from Tumu in the evening, park at Goel. Then they do all the vegetable shopping, load the trucks, and leave in the evening because it's cooler.
Okay.
Yes. So it means indirectly the Navrongo he mentioned, the last speaker mentioned, is even supplying Upper West.
Wow.
Yes. And that in several trucks. Then they move late evening because the road is good and they take their time and get there. So they supply to move, and by extension it goes to Wa, Laura, and so on. So.
Yeah. I think so, one of the dams too that is currently in operation too is the Tamne Dam too as well.
Tamne, yes.
Yeah.
Yes. Tamne, and there's one too at even Tili.
Okay.
Yes.
Yeah.
There are a lot of dams to do. Even Navrongo, we are only talking about Tono. There are a lot more because the Ministry of Agriculture, they have a record of big dams that you see. And the Tili one was noted for onion seed production.
Okay.
Yes, it was very good at onion seed production.
All right. We still have a lot to talk about, but then time would not permit us. We would have to wrap up and end the conversation here. So before Prof give us his last word, let me share this with you this morning, that if you are a business owner looking for a smarter way to keep an eye on your shop, restaurant, or warehouse anytime, anywhere, well, MTN Business Eye is here for you. Keep your business secure anytime, anywhere with MTN Business Eye, the smart surveillance solution that gives you total visibility and control. It is powered by Wi-Fi, SIM connectivity, cloud storage, and solar energy. So your security never sleeps, even when the lights go out. That is the magic. So enjoy 24/7 monitoring, real-time alerts, two-way audio, and reliable backup, all at affordable rates. So what you need to do is to dial star 5060 hash, star 560 hash today, and keep your business in sight always with MTN Business Eye. MTN everywhere you go. So we're having a discussion, an in-depth discussion with Professor David Miller. He's the president of Miller Open University here in the Upper East region. He's a development expert, and we've touched on national issues regards to the current initiative that has been launched by the president on free primary health care. And this time around, he's just throwing his views on the government initiative to expand tomatoes production in the country. And we're taking his last words on that, so we say goodbye to you. Prof, maybe your last words before we say goodbye.
Okay. I think it has to reach the minister that once upon a time we airlifted tomatoes from Bolga to Accra by air. That would dawn on them about the potential of tomato production in the Upper East region.
All right.
Yes. During Honorable Abulu's time, PNDC, Minister for Upper region there? Because the region was changing.
Okay.
Yes. There was so much tomatoes. And Accra again was crying that they didn't have tomatoes now. So he organized a military plane and they came and airlifted it from here to Accra.
So we've done it before.
We've done it before.
And we can do it.
And we can do it and even do more. Creating the right atmosphere is necessary. Having the policy consciousness. And when you are framing your policies national, please, note. No, you see, the problem I have with the policies is that when you are making policy arguments, you always say the North is the poorest, the disadvantaged. That's what they make all the books, even World Bank books. Now, when it gets to action, they forget about this background data they have provided. They forget completely. They don't. So they just use us to make a case. Then the resources come. Then they forget that we exist. And then the next argument, they make the same arguments again. We are still very poor, you see. So I think we should be sensitive to this. Have the national policies, but make them regional sensitive.
Okay.
That will let the whole country grow. If you ask me, the strength of the chain is in its weakest link. So for me, the weakest link in development intervention is the North. That is what the data they provide. I will target that one. Make it so strong that if it evens out with the others, you have made it. That is my last message.
Thank you very much, Prof. We appreciate that. So you heard him, Professor David Miller, shared his honest views with us this morning on current government policy to expand tomatoes production in the country, and that government should take a second look at the decision to side this at the Afram Plains area, and that the northern part of Ghana is up and ready to accommodate this particular policy. Thank you very much for joining us, have this conversation this morning. My name is Seidu Mutawakil. Show is being produced by Moses Abba Apia, Samuel Adagom, Gerald Asagi, Max Smith, Joseph Yaro. We call him Bra Kalala. After this, he takes over to ensure that you work and enjoy your work this morning. Work and happiness is next. And we're saying bye-bye from us here. And enjoy the rest of your working day. It's a beautiful Monday. Have fun. And do good even if no one is looking at you. Bye-bye.